All right. Good afternoon and welcome back again. Now we are at our Bariatric Friday. We are done with all the boring topics, so the most important one. Well, actually, the first one wasn't boring either. So our Bariatric Friday session, we are going to actually cover weight loss drugs and bariatric surgery. Dr. Irgau is here in our studio. Dr. Irgau, how are you doing?
I'm doing great, Kemal. Thank you for having me again on this wonderful Friday.
Thank you. And as I mentioned, our topic is weight loss drugs and bariatric surgery. And as many people are struggling with these issues, the options for patients or people to have an understanding what these options are is extremely important. With the rise of new medications like Ozempic, Wegovy, many are wondering how this is changing our approach or how the patient approach is changing, and which one is going to benefit the patient the most, when it should be used, if it's better to use the medication versus if it's better to go with the surgery. Are they actually competing? That's what we are going to discuss today. And so you're going to actually help us with that.
Absolutely. So, like many other disease processes, in medicine, we've very often seen the evolution of treatment modalities. Right? On the one hand, you would have medications. On the other hand, you would have surgery. And both treatment modalities may be appropriate for that disease process. But obviously, one of the things that doctors are good at is try to understand the place of medication versus the place of surgery in that disease process. So similarly, when it comes to the treatment of morbid obesity and its complications, things like type 2 diabetes, high blood pressure, sleep apnea, and so forth, it's not a situation of either or, right? It is very easy from a layperson's point of view to look at medication and say, okay, there are medication now, so no more surgery, or to say, you know what, I don't want medication, I'm just going to go for surgery. See, so those kind of viewpoints where there is almost like a binary type of choice are natural. People are naturally geared to thinking that, because it's important for us as healthcare professionals really educate people that, first of all, these two modalities are not exclusive of each other. Okay, we are extremely happy as physicians who's an interest in the treatment of obesity to know now that we have more than one way of dealing with this. Okay, and obviously there are places where medication is appropriate, and there are places where surgery is appropriate, and there may even be situations where both may be appropriate. So that's really an important way to look at this.
Part of the issue that I see is, and you and I, we talk about this a lot, perception and expectation versus the reality.
Mm-hmm.
What's going to happen? Well, there's a treatment option. Well, it's not magic, right? So we always say this, and so many times, if someone goes back and just runs some of our old videos, they do those collages. So this would be another one that I say the same thing again and again and again. This is not magic, but the overall public, they really don't understand the level of morbid obesity and what we deal with. So you and I, we do daily case conferences, and the patient that we deal with is not like BMI 26, 27, 28, but minimum of 35 and up, 35 to 40 with different chronic conditions. Mm-hmm. And 40 and above. We have a patient today who was on the specialist, BMI 82. So now with this patient, the worst thing that we can do is nothing. So there's medication, you use medication. There's surgery, you use surgery. But what's the most impactful is what we need to really understand.
Yes, absolutely. So first of all, let's put let's give some background on what those treatment modalities are, right? So if you look at medications, for instance, there has been clearly an evolution. Until not too long ago, the only medications that were available for weight loss were things like phentermine, which is an appetite suppressant, or something like orlistat, which is a medication that blocked absorption of fat in the intestine. And those medications, in terms of the results, what people were seeing, the results were very variable, but they were also very modest, in the big scheme of things. So, the best you could achieve was like a 10% weight loss, which meant that if a person is about 300 pounds and they really need to lose 100, 120 pounds, they would be losing maybe 25 pounds, 30 pounds at best, right? And this is being on those medications constantly. And then, of course, there were other medications like Contrave, which is a combination of an antidepressant and then an opioid antagonist. And those medications were still giving those kind of modest results. And then more recently, we have seen these new classes of medications that were supposed to have been developed for the treatment of diabetes primarily, but then we saw that there were very good results in terms of weight loss as well. These are the so-called GLP-1 receptor agonist medications, and people know them obviously with their brand names, things like Ozempic, Wegovy, and then obviously Mounjaro and Zepbound, which are even more advanced type of medications. And with this, we are seeing some much bigger results in terms of weight loss. And then at best, we could see up to 20% and sometimes even 25% weight loss, which means that a person who is about 300 pounds could expect to lose up to, 60 pounds or 75 pounds, which is really significant, right? So this is a definitely important advancement when it comes to those medications. With weight loss surgery, which has been around a lot longer than this new medications, obviously the results are very, very much more impactful, right? So we would see 30%, 35%, 40% weight loss with this medications, which means that, people could lose, or somebody who's 300 pounds would be losing 100 pounds, 120 pounds over a relatively short period, right? So yes, there is a place for both of them. Now, we have to look at the benefits of medications if you are avoiding surgery, obviously. But with surgery, you're seeing a much prompt result, right? So what is the place? What is the individualization? That is really the key. So if you are faced with somebody who is like a 50-year-old man with a body mass index of 50, who has type 2 diabetes, who has high blood pressure, who has sleep apnea, that person has an really serious healthy issue that needs to be addressed very quickly, right? And addressing that very quickly would be offering something like a sleeve gastrectomy, where the weight loss would be very prompt, it would be fairly drastic, and it would address the medical problems quickly. When you have type 2 diabetes, when you have high blood pressure, and you are at that level of weight, you are at risk of having a heart attack, and you could die anytime. So that serious issue requires really a prompt solutions, and surgery would be more appropriate. So on the other hand, if you're a relatively younger person with a body mass index of 38, perhaps with a recently diagnosed type 2 diabetes, and you're looking maybe to make an improvement by losing 30 pounds or so, then looking into medication and then training that person and getting that person into a good program would make more sense, right? So those would be like extreme examples of where choosing one versus the other may be more appropriate, right? Now, this is a general guidance, right? But then there are situations where, we have to be able to explain the complications as well, right? Obviously, with surgery, and as we've said many times in our Bariatric Friday, bariatric surgery has come up into a level of safety now, which is unprecedented, because we have been routinized so much. We had to prove ourselves beyond many limits to show that this was safe surgery, and that helped us really elevate the safety process. And we always say that sleeve gastrectomy, for instance, now is comparable to something like gallbladder surgery or hysterectomy in terms of its safety profile, right? And how about the medications? Well, there are side effects of medication, but one important issue about medications, particularly these relatively new medications, Kemal, is that our experience with them is relatively short in terms of how many years they're having. right? Whereas with bariatric surgery, we have been doing them for almost 30 years, and we've had hundreds of thousands, if not millions of people who had this surgery over the years throughout the world. So we know what we are getting, right? With the medications, yes, we've seen the potential side effects that can occur over 2 years, but we don't know what the side effects might be if somebody's going to be on them for 4 or 5 years or 10 years, God forbid. So there are these unknowns that have to be taken into consideration. And the reason I'm saying that is because what the trials have shown us, Kemal, is that once people stop these medications, the weight regain is almost so quick. It is amazing. Those people have to be on those medications for that weight loss to persist. Whereas we haven't seen that with surgery. Obviously, surgery, you do it. Yes, there are people who can struggle with some weight regain, but by far the vast majority of people are able to keep a significant amount of weight loss, forever. So essentially, again, the main message to be given would be that it should not be an either or, right? It should be individualized. And the greatest news for us in the field is now this is creating awareness among people who never have thought of obesity as a disease, right? You have people who would be walking with a body mass index of 54, and their only concern would have been the fact that they cannot tie their shoelaces or wear something that they want. Health issues related to obesity are coming right up front right now, and it is a great step forward in terms of educating people that obesity is not just about appearance, about quality of life and problems on a daily life, but it's a serious health issue that has to be approached this way.
So I want to actually bring up a couple of different issues here, Dr. Ergau. So one is if going back to many of our discussions, and including in our ACO, in our accountable care organization, one problem we had wasn't like, oh, there are so many different treatment options. Problem was there was no treatment. So we have patients with 40, 45, 50 BMI, and providers would feel, hey, it's none of my business. I don't want to embarrass the patient. So we came from that to the point of, hey, we have now options.
Yes, absolutely.
Right?
Absolutely.
So that's kind of like the key. So I don't want people to think that, hey, look, they're like trying to kind of, put this one over the other one. Hey, only 1% of the people who are qualified are getting surgery, just 1%. There are 100 people qualified to get surgery, 1% getting it. Yeah. So it's not about who's doing what, it's about how the resources are being used. And for which cases, the appropriateness of these cases, which method would be better is the key. Now, I'll ask you one question, which, you are more politically correct than I am, and I don't want to put you on the spot, but like I hear like a couple of primary care, I won't mention names. Hey, I don't want to give Intermittent for the patient. I'm like, why? Why would you not want to do it? Like the first medication that was available for weight loss. Oh, that's just, well, there's no specialty for that. So you're a primary care, you should be able to handle that, right? Oh, well, I don't want to get into that. Well, the patient has morbid obesity, so you don't see that as a problem, right? So we have those issues 99% of the time that's still out there. So medication is available, and some providers may not feel so comfortable. Well, get comfortable, right? So we want this to be utilized, because the problem is what we are able to get today is 1% of the total population that's eligible for morbid obesity, for bariatric surgery. So because we still have that level of, hey, I'm not going to prescribe this. Well, it's not like patient is given a choice. So I mean, it's a new medication you need to learn, and you need to get yourself, up to date, and that should be available to the patient. Because our problem is, and from part of our MSA QIP and us being the local chapter for Delaware for ASMBS, we understand and we know that morbid obesity is not being treated. I mean, we are never going to fight over which treatment options are going to be better, because we are maybe 100 years away from that point, right? So because I still have a couple of people just recently reported to me that, hey, I don't want to get into this medication. Well, what do you want to get into? Like, treat the disease. This is not a nose job or a boob job. Like, this is a chronic condition that patient has. So I'm glad from that point that medication is more and more accessible because it's bringing the awareness of this morbid obesity issue. As now patients are saying that, hey, this drug was available, how come you're not giving me this? Or can I have this? Is this the right thing for me? And we are saying that, yeah, that's a great thing to have.
It is. So it's interesting, right, Kamal, because up to, because of the stigma associated with what causes obesity, and then looking at obesity just as an appearance issue, or looking at obesity as something that is related really to how a person lives or doesn't live. That kind of view of obesity has pervaded for so many years, obviously, right? And up to recently, when people think about weight loss, they would think about, a diet that I can buy, or I can go into Weight Watchers, or I can do Slim Fast. So you're looking at some type of branded, approach that uses food and diet, etc., to help you lose weight. So that was the view we had. When you're talking about medication, the perception changes because medication is used for a disease generally. You don't take a medication for something that's not a disease. Generally, you take a medication if there is a disease. So when people start opening up to the idea that medication is necessary for obesity, then now we have a different level of discussion, right? Now you don't go to just some diet on a shelf of the supermarket to treat this problem. Now you need medication. So you're looking at it in a different way. That's why, when people ask me, as a bariatric surgeon, do you feel threatened that there are medication? My answer is absolutely not. In fact, I feel gratified that there are medication now because the awareness of obesity, of a disease now has gained ground. Similarly now, to your point now, if our providers are going to look at obesity as an issue of individual responsibility, willpower, appearance, then they're going to say, you know what, I don't deal with that. You go to a specialist. But when they look at obesity as the root cause of the patient's diabetes, high blood pressure, sleep apnea, arthritis, infertility, stress urinary incontinence, headaches, heartburn, and all this myriad of problems, then using a medication to tackle it is not only acceptable, but it is imperative, as you say. Before, right? It wasn't even discussed as an issue, right? Now we discuss it. When a patient comes to me, for instance, for a general surgical problem now, let's say a patient comes because they have a hernia or a gallbladder problem, and I see that person's body mass index is 38 or is 45, I do have to talk about that. I cannot let that patient leave my office just talking about the hernia, because there are implications about obesity and hernia recurrence, right? There are implications about risk of surgery and gallbladder surgery that I'm going to talk. So yes, you don't want to be presenting the problem as if you are judgmental. That is important. So my approach, for instance, to patients when I introduce this, and it's the first time I'm meeting them, and I say, hey, are you comfortable with the weight you are at, right? You ask them that question to just try to understand if patients look at their weight as a problem. And once that discussion opens up, then they give you permission to really talk about it. And then you can educate patients about how important it is for them to lose weight, regardless of the hernia issue that has brought them to us. So it is really a central problem in the health of patients. So the fact that we have medications for us right now, it just gives us an additional tool to address it, and it's great. It gives us an additional avenue to improve awareness of obesity as a disease. So it is a great thing that we have it. And as I said before, as healthcare providers, we are used to looking at different modalities for the treatment of disease. A classic example, for instance, is cancer, right? We don't say, okay, you have cancer, would you like chemotherapy or surgery? right? We don't go that way. We say, well, this is this type of cancer. The treatment is best if we start with chemotherapy, we follow it with surgery, or we start with surgery and follow it with chemotherapy because we want to eradicate that problem. And if adding these two modalities is the best way to do it, so be it. And we may have to do that with morbid obesity as well. If somebody comes with a body mass index of 65, it may well be a good idea for us to do medications to bring that weight down a little bit and then do surgery afterwards, right? So that is really the way we want people to be able to approach this issue.
So like there are so many different ways of losing weight, right? So when you were actually explaining this last part, like if we are concerned with the weight loss drugs, about 2 years ago, we opened up the discussion of intermittent fasting, right? So if someone effectively, efficiently do it, just not by diet, the fasting itself, but with other things that they need to do, they can actually lose weight. So it's not our goal is to get the people to do the surgery, but if it's the right person that should have the surgery, we want to make sure that that's done.
Yes.
So, another example that I'm taking, this whole perception issue is, it's just, I don't know if in my lifetime I'm going to be able to overcome this issue of people's perception, reality, approach overall. So when we didn't have the COVID vaccine, everyone was freaking out. Everyone, every friend of mine was like, when is the vaccine going to be available? When is the vaccine going to be available? So, and then vaccine became available. They put a lot of efforts, work, and it came out earlier than anticipated. So before it was available to us, the physicians needed to get the vaccines so that you guys were safe first. So we needed to be a healthcare employee to get the vaccine. So people were fighting vaccine. Right? So then once you get it, and I know that the entire hospital system get it, then we said, hey, we want to make sure we get it too. And some friends were like going out of their way. And then if you remember, it was giving you only 5 vials versus if you are a pediatrician, they do better with vaccines, so they can get 6 out of that. They wouldn't waste. So we would find people to get the 6th one. Vaccine became available. Every country made their own, and now people are like, the vaccines are evil, right? So and then they're blaming what happened. It's not all everyone, and I'm not judging them. Everyone has entitled to have their own opinion, but I'm just describing what was happening. I had friends who were trying to come here from different parts of the country to get vaccine. I'm like, hey, we can't do this. Like, it's limited, so it's only for Delawareans. Oh, we'll be in trouble. No, then after it was available, they're like, I don't want to get it. So hey, like, this is like, everyone's fighting for. I'm not gonna get it. Okay, so now let's look where we are today.
Right.
So this needs to be understood correctly. The reason I'm giving these 2 examples is because I'm going to go back to the initial issue. This disease was not being treated.
Yes.
And the issue of not being treated was the main thing. So if right now I'm going to give you an example, and I'm going to put you on the spot. So if my cholesterol was 270, my lipid values, the bad one is 270, and if you learn about that, would you not make any comment?
I would definitely.
Why?
Because it's important.
But why? Why? Like, you wouldn't worry about my feelings?
No, because
right.
I mean, it's all about understanding the dangers, right?
But so, like, you wouldn't worry about my feelings. So, but if my BMI was 42, would you say something? Not as a bariatric surgeon.
Yeah.
Not as a bariatric surgeon. Would you say something?
You mean as a layperson?
As a
as a pro. Non
But
bariatric.
take your bariatric surgeon out of it.
Yeah.
If you saw like someone you did business with 10 years ago and then they gained 120 pounds, you're not going to tell them, I know you very well. You won't tell them, hey, you gained so much weight.
No, because that discussion is actually, that's different, right?
Well, it's different, but it's just like the taste of it. So the problem is that's because we are treating morbid obesity as not a disease. Our mindset is not this not this is he just he put 150 pounds, nothing wrong with him, versus oh my god, your A1C is 10, you have to see an endocrinologist.
Yes.
So you're not on medication and you are freaking out. And you are getting Dr. now opening his office on a now Sunday to get those patients in. Yes. So this is just like this what's happening here is so interesting. And
absolutely,
at different levels.
But that goes to the real issue here, right? How are we looking at obesity? And you're absolutely right. If I saw somebody, for instance, that that I haven't seen for a while, and I saw a lesion on their face, and I know that lesion could be a cancerous lesion, I would point out to them and say, did you get that checked out? That's what I would say. But you're correct. If I have seen that person after so many years and they have gained so much weight, I would not make that comment directly. Now, knowing what I know, I would absolutely make sure that in some way that discussion is raised with that patient, with that person, because then I don't care about it, right? If I don't say something, it means I don't care about it, right? But the barrier there, why am I so readily capable of discussing the lesion in their face, but I cannot discuss the weight? It's because the perception, right? The idea that weight has to do more with the person's behavior and lifestyle, and it's their responsibility, as opposed to something that is much more complex and potentially deadly. I give you the example of the 50-year-old person with a body mass index of 50, with type 2 diabetes, with high blood pressure and sleep apnea. That is a ticking bomb. It needs to be addressed and addressed promptly. That's why surgery would make more sense in a situation like that.
So I'll change, I'll go back to the weight loss drugs with the alternative. Let's see if we are looking at an alternative or not. You were saying it earlier, and I just want to kind of I want to open that up a little bit. So when we do gastric sleeve on someone, let's say with 47 BMI, with diabetes, and let's say if they have sleep apnea, when they're able to get to the point where they lose weight after surgery, during that time, they're not on any medication. In fact, they're going to actually drop other medications that they have.
Yes.
We don't even send a patient with pain medication after surgery, right?
True.
So then once I pick up other things like the fitness and the overall changes in my diet, that's permanent. Right? So what I want to understand from you is this is not the case with medication. So it's not going to get me. It may get me to the point, but I'm going to always need that. So it may be a really good way to have a jump start or help the process, as I said earlier, with those patients with high BMI to bring them down. And that's what's the reason that we are using intermittent fasting, not because we are giving them as an alternative. Hey, you need to lose 70 pounds before the surgery because it's not safe for me to do surgery on you. Your BMI is 69, so 60 would be ideal. And if you're a male, then it's 55 is better. So in this case, the dependency is something that I would understand. So it won't go away. So
let's look. It's an interesting point, right? Let's look, for instance, at the more recent medications, the GLP-1 receptor agonists, right? What are they and how do they work? Well, these are actually medications that mimic substances that we already have and are naturally produced in our body. Okay, these substances, however, when they are naturally produced in our body, they are produced in much smaller quantities, and they don't stay in circulation in the blood for too long, for very, very short period. But what it is that they do? Well, actually, they are messengers that, for instance, lead to better blood sugar control. they lead to slowing down of digestion, and they actually act on the brain as well to decrease hunger. Right? So when you are able to manufacture them at higher doses and then give them as medications, those effects are happening, right? You're slowing digestion, you're controlling blood sugar better by acting on the production of insulin, and also you are decreasing hunger by acting on a particular part of our brain called hypothalamus, right? But this activity has to be ongoing for you to have the same effect. That's why you need the medications. And as soon as you stop the medications, the hunger comes back, the digestion is quick, and the blood sugar is no better controlled, right? So you need those medications in an ongoing fashion. How about surgery? How does it work? Well, surgery interrupts the communication between the digestive tract and the brain in a beneficial way. But that interruption is permanent, right? Because if you remove that portion of the stomach with the dual-slit gastrectomy, you remove this completely. If you reroute the intestine when you do gastric bypass, you reroute it permanently, right? So the effects of surgery are longer lasting because of that, right? Whereas the effects of the medication are dependent on the presence of the medication. That's why you have to continuously take that medication, right? Now, granted, as you say, you can have the medication, lose the weight, and then hope to be able to keep that weight off, right?
I think I was just thinking about that. So I think, explaining or understanding the chronic versus acute, right? So with the chronic problems, medication is only going to help us to manage. Like that's maybe like patients and people who are watching that may be confused with that. Medication can help. Let's say someone lost their significant other, and now they're in depression. It's acute. So they are going to be able to get some help with some medication, with the idea of they're going to get off that medication in the next 3-4 months or 6 months.
Yes.
But if someone has a chronic depression, in order for that patient to manage the depression, they have to be on the medication forever.
That's a great point. That is an absolutely great point because it highlights the fact that obesity is a chronic disease. And that's why we talk about that. It's a chronic, progressive disease that requires a long-term approach. And that is the key that we're talking about.
Or a game-changing outside of the regular treatment options to see, okay, we are going to interrupt that entire flow, and then we are doing the surgery that whatever we were assuming that was happening is no longer happening.
Absolutely.
So that's kind of maybe would help people to understand this.
Yes.
So I don't have chronic obesity. I have friends who may have chronic obesity because they were always morbidly obese.
Yes.
So that part needs to be really. I mean, you have seen me probably 25-30 pounds lighter, and probably have seen me 20 pounds heavier than I am right now. But none of those triggered the chronic problem of obesity.
True.
So if I'm using the help, just like similar to the gastric balloon, if someone is at BMI 30, 31, needs to go down to 27, fine, let's try this. But we are talking about serious level of obesity, and it's a chronic.
Yes.
So you don't take the patient off medication because A1C is now under 6. Well, they were taking 4 medications to get to that level. So that's maybe that will help people to better understand.
Absolutely. So really to just look at it again, what I think is important, the message that is important from our point of view is that there is no conflict between medications and surgery, right? The important thing is with the acceptance of medications, we are really getting more people to accept the fact that obesity is a disease. This is extremely positive, right? And then if that opens up more and more discussions between the providers, the healthcare providers, and the patients about the need for treatment, I think we're in a better place, right? And then we can discuss openly about what may be appropriate. Clearly, autonomy is very important here. The patients have to be comfortable with whatever method we propose as the best method, and they ultimately will make that decision because it's their body, right? And there is obviously no issue here. But when we fail is not when we're not imposing the treatment. We fail when we are not educating about the need for the treatment. And we're not educating patients about the consequences of avoiding treatment. Right? That is very important for people to understand. And once we've done that,
just so that this is kind of important, so again, people have a better understanding. Just this morning, I have a patient who has independent glucose. The prefix starts with YXF. They don't have bariatric benefit. So, have you ever heard of not having a diabetes benefit of any health insurance? Right?
Yeah.
So, how wrong that is?
Yes.
But this is why we are actually trying to make people understand that this needs to be treated first.
Yes.
Like when you say, hey, you won't cover chronic kidney problems so bad, so that you have that, the plan is written in that way.
Again, it's about complete discrimination about obesity as as a legitimate illness, right? Because that particular insurance plan is excluding bariatric coverage because that's what they have proposed to the employer, probably, right? If they had proposed to the employer, as you correctly said, okay, you can choose this plan that excludes treatment of cancer, or you can choose the plan that excludes treatment of high blood pressure, the employer would not take that, right? But when they say you can exclude the treatment of obesity, it's an acceptable form of discrimination, if you think about it, right? It's still acceptable. And the insurance company is getting away with that because society is accepting that, right? There is no uproar or outrage about the fact that an insurance company is capable of denying treatment of this. But we are making headway, right? And the development of these medications, in my view, is helping us. It's not hindering.
I'm confident with it. I'm glad that we are, instead of just this is not being treated versus now we have alternatives, and alternatives are kind of like fighting over which is better. So we are in the right direction.
Absolutely.
So, Dr. Erkan, thank you for joining me today. I think this is important because I hear a lot of people asking the same questions again and again. Oh, like you're going to do less surgery, or you're going to do no. This is what it is. So, but whatever you heard is what we are saying. Bariatric surgery is the most effective tool for morbid obesity. If you have chronic obesity, this is the way to do it. We utilize medication when it's needed.
Yeah.
We utilize other diet options such as intermittent fasting, raw diet. So it's never by itself, but most importantly, making that commitment and then changing the lifestyle and adding fitness, adding diet regime into your day. That's going to be the key.
Absolutely.
So we'll be back with another topic. Next week, we are going to have a premiere, and then most likely following week, we'll have a live event. So until then, please stay safe. Let's see you soon.
Thank you.
Bye-bye.